Hello, noson dda chroeso. Good evening and welcome to this week's Tomorrow's Podiatry podcast. Thank you all for tuning in. My name is Bryony Kate Jeffries and I recently graduated from Cardiff Metropolitan University, my bachelor's degree, and I'll very, very soon be starting my master's degree in the theory of podiatric surgery at the University of Huddersfield. Our expert this week is consultant podiatric surgeon, Mr. Ian Riley, who I'm very pleased to welcome this evening. Welcome, Ian.
Thank you, Brian. I'm just going to go and Google the word expert, but thank you for that. It's a little strong, maybe, but I'll take it. It's been a tough week.
Well, of the two of us. Tonight, our focus, as you have all guessed, I'm sure, is surgery, the surgical strand of podiatry. In particular, tonight, we're going to look at a condition I'm sure we've all come across, hallux abductor valgus. Ian has, I won't take your credit there, Ian has compiled a short PowerPoint for us this evening. However, Tomorrow's Podiatry is all about the students, about you. So this is an interactive podcast. So we welcome all of your questions. We've got Ian pinned down for an hour tonight. So if there are any questions, anything you'd like to ask, please do so. Please comment below and we'll be keeping an eye on those and we'll try and do our best to get through them all.
Brian, don't be modest. You put those questions together. They were really good questions. So what we've tried to do tonight is come up with some kind of like undergraduate questions you've always wanted to ask, I think, and I'll do my best to answer those. But as you say, hopefully we'll get some questions coming in from the guys out there, because I do much better being put on the spot and being made to think a little bit.
Well, perhaps I'll have to think of a few while we're going through. Keep you on your toes.
Haha! Is that the first gag of the night?
Do you know what? It didn't even click then, but yeah, I'm going to take that. Complete accident. Should we have a look at your amazing podcast?
So we're going to go into the PowerPoint there. So
your PowerPoint. Sorry.
Well, we can make it a podcast. Mike in the background might make it a podcast as well as a YouTube and a Facebook Live. So Brian and I put together just a PowerPoint of a few what we thought might be fairly standard questions. So Brian, really the credit's all down to you, because you came up with sort of questions you think you might want to ask yourself. So about me, what am I? Well, I'm jobbing podiatric surgeon from Northampton, qualified as a surgeon in '96, so that's 24 years ago. Bunion's probably the surgery I do most. It's probably my biggest referral by number. So I've done about 2,000 bunions, and I've had a few trainees come through. So there's another 1,000 bunions or so that I've mentored, or that my trainees and students have done. So I have a familiarity with the condition. So way enough about me. Brian, should we jump into the first slide and see what that first question was?
Yeah, sure.
So what parameters must a patient and their bunion meet to be eligible for surgery? So that's a really great question. So I used to run, back in 2000 to 2002, I was a lecturer at Northampton, and I used to run a 12-week module on podiatric surgery. And really the aims of the module for each of the different subjects. So we did a week of soft tissue, a week on digits, a week on bunions, a week on hallux rigidus, etc., etc. And really the main effort of the module was really to give undergraduate podiatrists an idea of what would happen with any particular condition, so that you would be in a position to refer off. So you've got a patient that comes through, they've been under your care, and they've done whatever conservative therapy you've done, insoles and taping and whatever. And at some point you might think this patient might be eligible for surgery. So it was trying to equip the undergraduate and the new podiatrist with that understanding of when to refer for surgery. But also the patients would ask, well, what's involved? And again, it was to try to equip the podiatrists with the ability to say, well, this is what's involved with surgery. depending on the presentation, we might break and reset your toe. There might be some metal work, and this is kind of what happens. So that was the main effort of the module, and I ran that for, I think, 3 years when I was at Northampton. Enjoyed that greatly, and the students of Northampton still come and spend some time with me. They rotate with my service in Northampton. So in terms of eligibility for a bunion, really the first thing I'd like to think is that every patient has had a degree of conservative therapy, and that's really kind of important. So even if I get patients sent to me direct from a general practitioner, which I get every day, so I'll get direct referrals in from GPs, I don't rush into surgery, and really no good surgeon should do that. We should have a think about, can we manage the patient's expectations? And so we have a chat, and I'm really patient focused on what I'm trying to achieve is what the patient wants to achieve. So I'll really say, what is it that you want? Do you want a foot that fits the shoe because you've got a bunion? Do you want to wear crappy shoes? In which case that's an interesting conversation, but that might be the patient's ideal, is to get into pointy or court shoes and the bunion is stopping them doing it. It might be that they've got an issue with function, or ideally it might be because they've got a painful bunion. So that's really where I'm happiest to recommend surgery. So ideally a patient comes to me having had conservative therapy, it's been tried and failed, and that they then are eligible for surgery based on the fact that they have, in order really, pain that I'm trying to reduce, function I'm trying to improve, and then cosmetics that will also improve as a result of surgery, I hope, but pretty much in that order. I will tinker about with that. There are times that I will accept that the cosmetic issue is the biggest problem for a patient, and I'll take that into account. And a couple of my colleagues are doing cosmetic foot surgery, which is a whole other topic. I'm happier if a patient, and it will typically be a female, who's having footwear accommodation issues. And I think that's a genuine thing, even if they want to wear relatively sensible shoes, so not overly fashionable, then I think it's absolutely fair to say, well, look, we can make your foot a little bit narrower so that it fits into shoes better. But ideally it would be reduction of pain, improve of function and footwear fit, and then cosmetics. After that, sorry, Bri, I'll carry on talking. Is that okay? After that, we need to then think about medical fitness for surgery, and then you get into whole issues of consent. So, I've had, 2 weeks ago, a lady came through, 94 years old, who's come through for bunion surgery.
Wow.
So then we have to think about, are you physiologically fit for surgery? And there's a difference between physiological age and chronological age, and I worry much more about their physiological age. I know many people who are old 50-year-olds, myself included, and this particular lady is a very fit 90-year-old with significant pain, and if she passes her pre-surgery clinical clerking, then she'll get surgery. Any comeback on that, Brian? Anything you kind of want in, and we'll see if there's any comments. Anything that you want to tease out of that?
No, I think that's great. It's a great answer. We quite often in university we just think of pain, I think, and although that's really important, a really important parameter to meet, or the bunion to meet, actually thinking about the cosmetic appearance and the ability of your patient to be able to wear the footwear that they need to or want to wear, and the impact that's going to have on them as a patient is interesting to, important as well to take that into consideration. Yeah,
I think it's about matching, and particularly matching what I think I can offer a patient and what the patient wants as well. So the patient goes through this journey, which will involve some risk and will involve some discomfort. And at the end of the day, I want the patient to be as happy as I am. And we'll sometimes have a disconnect. We'll sometimes have a really happy patient and an unhappy surgeon because I don't think I've done a good enough job. Sometimes it'll be the other way. I think I've done a great job for the patient, but the patient says, oh, my toe's not as pretty as it should be, or vice versa. So I think I've got a little bit better over the years of trying to work out what it is the patient wants. And 2 or 3 weeks ago, I had a patient that came through, being referred by the GP kind of under duress, and the GP, and I'm the biggest fan of GPs, by the way, but the GP had been really quite dismissive of the patient's concern, which was it was mostly cosmetic. There was a footwear issue, but it was the other way around. So it was cosmetic, footwear and pain in that order. but she was really not happy with the foot at all. It was the sort of patient that doesn't want to get her foot out in public on the beach. And I said, you know what, I can see that it's troubling you, and I'm quite happy to take that patient forward for surgery. And she was almost in tears because she'd been listened to, and I was happy to do what she wanted me to do, and I didn't feel that it was unjustified. I mean, you know, if people will pay, as they do, thousands of pounds to have cosmetic facial surgery, say, why is it such a problem to have cosmetic foot surgery, provided that you know, we counsel the patient really well and saying, look, this is a surgery you're going to have, but it can go really wrong. I want you to understand that. And then if you've got informed consent, I honestly think that's fair enough.
Yeah, I agree. I think it's a really important thing to remember, to treat the patient, you know, holistically. And if it's something, like you said, if she's not wanting to get her feet out on the beach and things like that that are going to affect her day to day with footwear, sandals, things like that, it's definitely an important thing to consider and look past the, you know, just pain being your indication for surgery.
I think I'd like to think it's the main one, but I don't think it's an only one. So we've had a couple of points coming in. Evelyn Ware, for those of you who don't know Evelyn, she is one of the lecturers up at QMU in Edinburgh. She is a very bright lady and also just one of the nicest pods out there. They do such a good job for the students up at QMU. Their paternal care almost to their students is great. So Evelyn, nice to see you kind of chatting. And then there's a question from Anna. Anna Evans is a podiatrist from Yorkshire, incredibly bright girl. In fact, Anna and I had a publication out a few years ago on surgery. So Anna asked about the rheumatoid patient. So within bunions, you've obviously got an angular deformity, but then you might have other things go on in the background. You might have diabetes, you might have different forms of arthritis, you might have wound care issues, you might have gout. So if you've got a patient with bad rheumatoid arthritis that would predispose that bunion being worse, typically, I always think about rheumatoid of whatever condition you're going to get biomechanically, functionally, rheumatoid makes it worse quicker, is how I think about RA. So typically that bunion will be bigger, floppier, and more arthritic. So in a word, Anna, that patient's more likely to have a fusion. And if there's a wound as well, then you need to think about the wound. Should we go back to the slideshow, Brian, and take the next slide up and see what the next slide was? Okay. So surgical correction of HAV. So Claire O'Kane and Tim Camartin, who are Tim Camartin, everybody will have heard of Tim. He's our top research podiatric surgeon. Last I counted, he had 76 publications to his name, PhD back before PhDs were a thing. One of the guys I look up to most in the profession, and not just because he's taller than me. Tim's got a really impressive research pedigree. So he had a really useful paper out in 2002, and I quote this a lot when I'm doing bunion talks, in terms of what it is we're trying to address surgically. And I think the things that we look to try and do, on top of those underlying aims, which would be pain, function, cosmetics, what will generally make the patient happy is if we improve the position of the hallux. So we talk about the abduction component of HAV, so transverse plane correction. Again, in the transverse plane, the intermetatarsal angles are making the foot narrower, and then within that as well, getting the sesamoid position. So those will be the top three things that we'll look to try and address surgically by some form of carpentry. And after that, it's first metatarsal length, and also in the sagittal plane, the up-down position of the first ray, and that's Tim's reference there. And they would be typically what I'll try and address when I'm doing whatever procedure. So it's a great paper that by Tim and Claire. As I quote it all the time, I've not seen anything better or more recent to say what is it we're trying to achieve with surgery from a carpentry perspective. No more questions coming in yet. There must be all of about 4 people listening, Bryony.
I love that you say carpentry. My partner's a carpenter, and I attended the conference last year and the sawbone workshop. And
you were on that?
Yes, I was there.
Oh, okay. so that's my fishing partner in crime, Julian Pavian, and I. So Julian was the good-looking one at the front with a see-through hairstyle, and we've done that for a few years now. And the idea of doing a sawbone workshop is to, with the podiatrists coming through, particularly kind of some of the younger guys coming through, is to kind of go, surgery is a real option for you as a career, and just to kind of get the tools out and have a bit of a play on plastic models. And it's seems to go down fairly well. We've done that for a few years, sponsored by Osteotech. Thank you, Osteotech. And we really enjoy that. And, a couple of years later, we've seen a few people go down the surgical route, and we flatter ourselves to think that we've helped, sow the seed for a few guys coming through.
Yeah, I thought it was fantastic. It really was. I took my is it plaster of Paris? Is it made of? I took that home.
It's plastic.
Anyway.
It's made out of plastic. We call them sawbones, but it's some kind of plastic. But
right.
It shows you how to kind of do some cuts. I mean, obviously, there's only so much we can do in an hour.
Yeah.
So
no,
next
I thought
slide.
It was great.
Well, that's great to know. What's the next slide then, Bryony?
Let's have a look.
What surgical techniques do you most often do for a bunion? Do you favour a particular one? So the answer is yes. Shall I expand on that?
Please do.
Okay. Have a guess.
Fill us in.
Have a guess how many surgical procedures are written up in the literature for correction of a bunion. Have a guess how many.
Oh my gosh.
Go big.
Go big. 15.
130.
130. Oh my god.
130.
There's no way I was learning all of those for my undergrad.
I don't know them all either. I know a few, but I don't know them all. So there's said, and you'll see this quoted time and time again in the papers. 130 different ways you can kind of move the bone from there to there, and it's wow. Basically people who are desperate to get their name in the literature and invent a new technique. I am one of them. I'm desperate to invent a new osteotomy, but I think I'm a bit too late to the party. So with those three aims of what we're trying to do for the patient: pain, function, and cosmetics, and those surgical parameters that I just put up the slide last from Tim and Claire, there's lots of different ways that we can try and achieve those aims, and we break it down. I love classification systems. We break it down again into three. So we have bump removal, we have some form of osteotomy, and then we have some form of joint destructive procedure. So if you have a little old lady of 94 and her problem is just a big medial bump, and she's got fairly osteopenic bone, she's a little bit wobbly, and she's not got great circulation, then you want to do as little as possible to that foot. And you might do an exostectomy. And then within that, there are a range of different exostectomy and soft tissue procedures. Silver, Hiss, McBride will be the main three. The silver bunionectomy, though, is effectively taking away the medial bump. So I've done that for lots of my little old ladies, just do a medial bumpectomy. So that's my procedure of choice for my old patient really. The biggest group are the patients that have some form of osteotomy. So we will break and reset the bunion. And then within that, the most common one in the UK is something called a scarf osteotomy. And going back to carpentry, that is actually the scarf cut, which is an elongated Z cut, is actually a carpentry technique, Bryony. So it's back from Egyptians at times, and it's a way of forming a joint between two long pieces of wood. That's why I call it carpentry. So the scarf, I think we've got a picture coming up, is the one that's most commonly done within the UK. But effectively, you go back to look at your angles. So the smaller the bunion, the smaller the cut to get that intermetatarsal angle straight. The bigger the bunion, the bigger the cut you have to do to narrow that foot down. So it then becomes fairly simple trigonometry, really. But the scarf gives you the ability to move the bone quite aggressively, and it's quite stable. And it allows you to employ what we call the AO principles, which are, if you remember AO, the AO Institute are, they're an orthopedic institute that function out of Davos in Switzerland. And they, after the Second World War, redefined bone healing and how to deal with trauma. And they developed a set of principles based on the trauma of World War II of how to get better results with fixing bones from breaks and trauma than was previously done from back in the days when you'd break a wrist and you'd be in plaster of Paris for 6 weeks, and when you came out of plaster of Paris you healed, but everything was really stiff. So the AO Institute have redefined how we deal with bones, and there are certain principles. So in terms of rigid fixation, early mobilization, maintaining the soft tissue envelope, and trying to get the correction of the deformity done, those are the 4 principles. And we use those principles and design osteotomies around them. And the scarf osteotomy just fits in really nicely with all of those. So the scarf's my favorite. I've done probably about 1,000 scarf osteotomies now out of my 2,000. So half the bunions that I've done have been a scarf, and then other forms of osteotomy. And then 3 types. So we talked about exostectomies, osteotomies, and then the last type will be a joint destructive procedure. So if you have a bunion that's got secondary arthritis, or is particularly big, or has had previous surgery, then it might be that you can't fix it and you've got to remove the joint. And you can do a joint replacement, you can fuse it, or you can remove it. Arthrodesis is probably the one we do most, and it's an aggressive option, but that's kind of option 3. So it absolutely depends on what the patient wants, what the foot looks like, patient expectations, and informed consent. But the simple answer is the scarf is my one of choice. Let's just have a see what kind of questions they come through while I have a little tickle. Excuse me, questions. So the question is coming from Connie. I'm really keen to pursue the surgery route, but told it will take a time to get there. As a mature student, would you agree? Well, it depends how mature it is. You feel it, but certainly these days, I'd really say that age is just a number. It does take a few years, so we are trying to condense that a little bit. But obviously, after your 3 years of undergraduate degree, it's then 3 years of doing a master's, which is now compressed to doing a 1-year full-time master's. It's then 2 to 3 years of being a trainee, and then 2 to 3 years of being a registrar. So it does take a few years, necessarily because we're going from podiatry to surgery. It's a big leap, so it needs to be quite a rigorous training. But there's lots of different step-offs on the way. I was chatting to an ex-student of mine who's now the other side of 40, and she was saying, has she left it too late? And I said no, go for it, because even if you don't finish, you'll get a master's qualification. If you don't become a consultant, you can have a master's qualification. If you start your training but don't finish, then you might become a specialist podiatrist as part of a surgery team. So there's lots of different step-offs because not everybody will make it to consultant. So I would absolutely say give it a go. Question from Yang, is podiatric surgery limited to mostly bunions? Absolutely not. So the scope of practice is the foot and related structures. So I do flat foot surgery, I do some diabetic surgery now, some amputations. Most of it is forefoot surgery, bunion, hammer toes, lumps and bumps. But no, it's we have an increasing scope now. What is the average day for a pod surgeon? Well, will be a mix of clinic and surgery. So today I was flying a desk. Tomorrow I'll be in clinic all day. Thursday I'll be doing some surgery, and Friday I'll be spending my winnings. We earn so much money in podiatric surgery. It is a stress to know how to spend all our winnings. Sean from Ireland says, hi Sean, don't forget you got to give me some dates to come over to Ireland and do some num jokes for the Irish. Katie Hutchins, if there are over 130 techniques, would you talk through a certain amount of these techniques with a potential patient? So that's a really good question. So in terms of informed consent, you're supposed to tell a patient everything, but you can't. So really, you will have to lead a patient and say, you've got some different options. You've got option A, B, and C, but I would recommend option B for you based on X, Y, and Z. But because of Montgomery, you've got to give the patient all the options so that they can form their own opinion, in theory. Now, that's what it says in law, but that's kind of nonsense. If I've got a registrar who's, my current reg, Aki, who's a lovely fellow. Aki and I have worked together since 2006, worked together for 14 years, and we will have an erudite discussion about what particular procedure is best for a patient. And sometimes I'll have to say, Aki, this is what we're going to do. And he'll go, oh, okay. How can you expect a patient in 20 minutes to form an opinion on what they think is best for their own foot? So I honestly think it's right to give the patient the options. But if a patient says, what would you do? Then I will say, if it was my foot, this is what I would do for my foot. And then you're not leading them. It's their decision, but you're giving them a hint. Yeah. Joe Bennett. Hey, Joe. Joe works as a podiatrist in Northampton. Much better than watching Boris. Not the best compliment I've had all day, Joe. Not the worst, but I'll take it.
Take what we can get.
Yeah, I've been called worse. A face that had startled a police horse, as you can see. And this is half an hour in makeup, guys. Okay, half an hour. This is me prepped. You don't want to see me first thing in the morning. Usama, salam alaikum, Usama. Loving the hair, Mr. Riley. Thank you very much. All natural. It's all mine. I bought it. Belongs to me now.
You grew it.
Yeah, it does that. People say, "Are you growing your hair?" I go, yeah.
You're like
You're growing your hair. I'm just not having it cut. So Sean's asked about juvenile HAV, asymptomatic, but mother's concerned. So that's a really good question, Sean. So you've got a patient that comes through and they're 12, 13 years old and they've got a bunion. So if you look in the surgery textbooks, there'll be whole chapters on juvenile bunions. And so there's a real, here's a conversation I have every day. So, Brian, I said patients come to you and they're going to try and deal with pain. Now, pretty much everybody, they'll start with no pain and they'll get some discomfort. And then at some point they'll have raging agony. But that's a slippery slope. Now, at some point, you can maybe manage that patient conservatively. At some point on that slippery slope, their pain will get such that surgery becomes better indicated. But that's going to be quite variable on the patient. So you will say, can you live with your discomfort? Okay, let's manage it with orthotics and shoes and taping. And at some point, we might get to the point where if your pain is sufficient that it becomes a problem for you, surgery becomes indicated. But that's down to the patient. It's what they want to live with. Now, on the other side of that, if you've got a patient that comes through in there, well, okay, I'll come back to juvenile, Sean, but say you've got a patient who's got a moderate bunion and they're 20 years old, it's going to be nicer to operate on that 20-year-old with a small deformity that's going to be easier to correct, with no secondary arthritis, with no secondary soft tissue changes, and they will do better long term, I would suggest. And what we need to do, we can't do it science-wise, you really need a 20-year-old with 2 stage 1 bunions, do one and not the other, and see them when they're 60. And what you'll find is the one that was done when they were 20 has done better long term because you've corrected the anatomy. So the patients that come through and they're kind of my age, trying to hang on to their hair, and they think they can get away with being kind of young and hip and cool, and they've got a big bunion with secondary arthritis, they're kind of difficult because now you're trying to correct the deformity and you've got some secondary arthritis in. So you fix the bunion, but there's still some wear and tear there. That's a difficult patient to manage. When they're 70 years old, it's easy to fuse them. So the middle-age group with chronic bunions with secondary changes is difficult. So take that back to the juvenile patient, Sean. It would be nice to fix that bunion sooner, provided you've tried conservative therapy before you've got kind of secondary changes. And I've seen 15, 20-year-olds with arthritis in the joint already because their deformity has been such. Now, I will do some pediatric bunions, at least I used to. I can't do pediatric surgery anywhere I am now because of the rules of working with pediatric nurses. That's a whole other topic. But I really think there's an argument to fix the pediatric flat foot, which I think, and I'm going to be a bit old-fashioned in that because I think overpronation is still a thing, and I think overpronation is the thing that causes bunions. Controversial. And I'm back when I was able to, I was doing pediatric flat foot, not huge numbers, but you could really make a difference if you actually feel if you treat the cause. But again, Sean, it's a slippery slope. So absolutely do everything you can with orthotics, but at some point their symptoms would indicate surgery, and I've certainly operated on quite a few teenagers. Rebecca's joined. Hey, Rebecca. Rebecca's also an MSc student. So should we go back to the PowerPoint while some more questions come in,
yeah.
Brian?
Some fab questions there as well.
Oh, yeah.
Really interesting. Thank you.
Did I miss a question? Let me just check.
Oh.
So Katie, I only answered half your question. 130 techniques. Would you talk through a certain amount of these techniques with a patient? I sort of half answered that. What's the thought process behind elimination of a patient has had one over the other? Okay, so the question I get asked probably every month is the patient has had a chat with their favorite doctor, and it's Dr. Google. Dr. Google is an eminent doctor, and he's out there and he does online consultations all the time. So I get a lot of patients who come through and they've read all about bunions and they know all about it. The question I get asked probably most is, what about MIS bunion surgery? So I'm doing PodChat Live with Ian Griffiths on the 8th of October. It's a Thursday, or was that the 10th? 8th. And I'm doing that with an orthopedic surgeon who's an MIS specialist. So tune in for that one on the 8th of October, and that'll be interesting to see. So you've got orthopod and pod surgeon, and I'm open, and he's MIS. So we'll kind of see how that one goes. So MIS is probably the question I get asked most, and patients will often say, I've read about MIS bunion surgery, and I will normally say, keep reading. So let's have a look. Next slide. How many surgeries do you perform a year? So overall, question 2. So I operate on a good year, 500 patients. So that's probably going to be about 200 bunions. Number of procedures, the average patient will get in like a typical bunion surgery might be 2 procedures, so 2 osteotomies and a hammer toe. So that's probably about 1,200, 1,500 procedures a year on those 500 patients, but about 200 bunions a year.
Wow, busy.
Oh, yeah. Type A personality. I don't like
saving the nation's feet.
Well, the ones in Northampton anyway.
The ones in Northampton. Shall we have a look?
Yeah. Next question. Oh, okay. So there's a picture. So this is a scarf osteotomy. So if you've got a right foot medial incision, can you see there's a kind of a long cut in that bone, Bryony? So if I kind of trace it out. So as I'm looking at the screen, I've got one cut from the top in the metatarsal head. So short cut, and then a long cut, and out the bottom there's another. So that is an elongated Z. So the cut is 1, 2, 3. And you do that cut in the transverse plane, and having done that, you translate or rotate the bone back into the position. So that's the scarf osteotomy. That's our fave. This particular picture is from a buddy of mine, Ben Yates from Swindon, and he's using a K-wire just to orientate the osteotomy and to help move it across. And that's absolutely fine to do. Speaking of Wales, Toby has just sent me a message on WhatsApp. For those of you that don't know Toby, he's a good buddy of mine from somewhere in Wales.
Somewhere in Wales.
I love Wales. I was in Wales fishing at the weekend. Love Wales. I keep trying to hint to anybody that will employ me in Wales, because I would move to Wales in a heartbeat. Absolutely love South Wales. So that's the scarf osteotomy, Bryony. Next slide, please. Okay, so this is one of my cases, and this is what they look like on an AP X-ray. So anterior, posterior, or DP, perhaps dorsal plantar will be better. Now, can you see that first metatarsal? It's kind of started off one way, and it's kind of rotated. So you've now got a rectus hallux. I fix that with wires and screws, and I could talk all night about options for fixation. But what I say to my patients is we shave, break, and reset. So we shave the bump off, we break the bone, and then we reset it where it needs to be. And then to hold it in place, that's using that AO principles. We'll use some form of internal fixation to hold it where we want it to be, so it stays there and it heals. And you can probably just about see that all those bits of metalwork are flush with the bone. So ideally, we don't need to take any of those out. So that's 2 osteotomies. It's a scarf osteotomy to the metatarsal, and it's an Akin osteotomy, AKIN, to the proximal phalanx. So scarf was first written up in 1926. The Akin was written up in 1925. So these are old techniques, but they've been refined and embellished over the years. And if you look at scarf osteotomy now, there's a dozen variants on the scarf. In fact, one of them is written up is called the trotation scarf, which I might have written up, he says immodestly. Questions coming in. John Darlington, what's the training program like for a pod surgeon, and how does it compare to orthopedics? So great question, John. So it's pretty much 3 years of podiatry, 3 years of an MSc in theory of pod surgery, 2 to 3 years as a trainee, 2 to 3 years as a registrar. So in theory, it's 11, 12 in total. We're trying to reduce that down a little bit because we are aware that that's quite a long time. So you can now do a 1 year full-time master's. So that means that out of podiatry school, you can become trained in the theory of pod surgery in 1 year as opposed to 3. And most of our training programs are part-time. So if you were to do 2 days a week for 3 years, that would be fine. But if you could get a full-time training job, you could do that quicker. Orthopedics is 5 years to become a doctor, and then it's 1 year as a it's going to be 1 year as a FY1 and FY2. So house officer, senior house officer in Old Money. Then it would be core surgical trainee program for medicine or surgery, and then 5 or 6 years as an orthopedic registrar. But within that 5 years, you'll do 6 months knee, 6 months hip, 6 months upper limb, 6 months spine, maybe 6 months pediatric, and then you'll specialize, towards the end. So, you're qualifying as a consultant orthopod by the time you are mid to late 30s. So you've got a massive amount of training. But for the foot and ankle fellows that are qualifying now, they do less foot surgery than a podiatric surgeon. So they have the advantage of being medical doctors. So I'll be the first to say they've got much better medical knowledge than 90% of my colleagues have, but they don't have the numbers of foot surgery. And also they don't, as a rule, understand biomechanics. They're not nuanced in, they might think that all plantar heel pain is plantar fasciitis, for instance. Another question from Katie: would a referral to a pod surgeon still be best for children, or referral through PED? So it depends on your pod surgeon, to be fair, Katie. So where I work in 3 hospitals, 1 NHS and 2 private. And over the last 5 years, each of those 3 hospitals has done away with paediatric services for different reasons, which has been a shame. So I used to do an amount of paediatric work, and that's now not something I'm able to do. So I can't operate on a 15-year-old who needs an ingrown toenail done, for instance, which is a nuisance. If you're in a district general hospital, so the one local to me, there's a very good foot and ankle orthopedic team, and the pediatric foot and ankle orthopedic is a very good surgeon. And if you went to him with pediatric bunion or Taylor-Pease, he's really good. So it really depends on what your local setup is. If you've got a good local podiatric surgeon, there's a couple of guys who are great with kids. Stuart Metcalf is awesome with kids. Mark Tago down in London, awesome with kids. Just off the top of my head, some of my colleagues are really good, but generally it's going to be foot and ankle orthopedics. And there's a real crossover in orthopedics between pediatric orthopedics and foot and ankle, because a lot of pediatric ortho problems are foot and ankle. So most times they're one and the same. Okay, Bryony, next slide. We'll see where we're at.
Let's have a look.
How long before the patient can resume normal post-surgery? Well, so that depends a little bit on the procedure. So if you've done a bump and run, as I call it, an exostectomy, it's going to be 2 weeks. If it's an osteotomy, it's going to be 4 to 6. If it's joint destructive, it's going to be 4 to 6 to 8. So it depends on the aggressiveness of the surgery, and then it depends on the patient, depends on how they heal, depends on making sure they don't have a problem. So you get a patient that does too much too soon and they will prolong their healing. So I had a patient last year, fractured her bunion. I'd done a scarf osteotomy, beautiful, absolutely bob on the table. And she came through at week 4, I did an x-ray, and it was all kinds of like Meccano gone wrong. And I said, okay, Deborah, what happened there? She said, oh, somebody stood on it. I said, oh no, where? In Sainsbury's. Oh, so what were you doing in Sainsbury's doing your weekly shopping? So it was difficult to unpick whether she had done too much or whether she'd been unfortunate and somebody stood on a foot. It was, so if patients do too much too soon, they will take longer to heal. But typically I'll say 4 to 6 weeks, but it takes 3 to 6 months for that foot to really settle down, and nearer the 6. So my typical surgery review isn't for 6 months. And time again, I will have patients say, I really didn't think this was going to get better. Up until about month 5, I was still a bit sore, still a bit swollen, still a bit stiff. And I'll say, that's why I don't see you till month 6. So it's unusual for patients to be fully healed before 6 months, and it can take longer.
Ian,
sorry, go on.
Sorry, Ian. Excuse me.
Excuse me.
Would you say? So, would you say, depending on the stage that they were at when they had the surgery, would it take longer to heal, or is it?
Indirectly, yes, because depending on the stage they're at. Do you mean stage 1, 2, 3, 4?
Yes.
Okay.
Perhaps we should expand on those a little bit as well.
Okay, so you can do, but you can't really be. So my stage 4 is 4 stages is mild, medium, large, and BFO. Do you know what a BFO bunion is, Bryony?
No, but I've got some ideas going around in my head.
It is a big fuck off bunion. So that's my staging. That's my stage 4.
I'd let you say it.
Yeah, don't swear. It's very unladylike. So the bigger the bunion, the bigger the surgery they're going to need. So it's not that the stage is going to take longer to heal. It's that they're going to need a more aggressive procedure. Hence why my comment about half an hour ago is, you know what, I'm kind of happier now to operate on a 20-year-old with a modest bunion, because that's going to be a better fix. They're going to do better. And I can't prove that to you because you can't do that science. But that patient's probably going to be doing better at 60 than if I operate on her when she's 50 with a bigger bunion with some secondary arthritis. Voice is growing. I have decided I was coming down with a cold today. Question from Evelyn. One of the things we are talking about with our students at the moment is managing patients' expectations. How do you do this in your own surgical work? That's a lovely question, Evelyn. So my patients, when they are first invited in to come and see us for a primary assessment, one of the things we do is we send them some information. So we first tell them that we are podiatric surgeons, because we have to stress that we're not doctors. It's one of the things that we're really required to do. We talk a little bit about what podiatric surgery is, so they understand it's not just kind of slightly advanced chiropody, it's surgery they're coming for. We send them a medical questionnaire because we want to know all about them, so it gets them thinking, oh, this is more than just advanced chiropody. And we also have a section to say, what is it that you want from surgery? So we actually get them to write that down, and so that it really helps us encapsulate, I'm in pain, I want to be able to get crappy shoes on, I want to have a pretty foot, or whatever. So we get them to write that down, and then that's backed up on our information that we have. It's all electronic where we are with a medical record, patient's expectations. So we write that down, which will typically be reduce pain, improve function, cosmetics, in that order. But we look to get that written down, and that's really helpful medico-legally when the patient comes back afterwards and say, we've had it, yeah, you've taken away all my pain, but I've got a little bit of a scar, and you might have a disconnect. And if you can be really clear, and I'm really straight with my patients and say, this is what I can achieve for you, I think, it's really important that we're on the same page. And, I've done a couple of these consultations now, and you can fairly quickly work out what it is the patient wants. That was question 4. Do you want to slip forward a slide, Bryony, please?
Let's have a look. Okay.
That was really nicely predicted there, Evelyn. How do you manage patient expectations to achieve positive results? So it's getting them to state what it is they want. It's us saying this is what we think we can achieve. It's being really clear about post-op recovery. So you know me, I love to classify things in 3s. Have you noticed that? So the perioperative phase, 3 phases: pre-op, inter-op, post-op. So pre-op is making sure that we're on the same page. Inter-op is doing great surgery. That's down to us primarily. And then post-op, and it can go wrong at all those stages. And that the post-op is really down to the patient. So you can do the best work in the world, and then the patients come back after 2 weeks and they've just had a lousy result. And that's down to the patient. So my lady who's in Sainsbury's, who somebody walks on a foot, but she shouldn't have been in Sainsbury's. So we really emphasize all that can go wrong. We want to instill just a little bit, not of fear, but of concern. And the patient takes on that risk. So that if the patient comes back and they've had a bad outcome and it's on them, then I will say that's on you. Sometimes you have to, be quite clear with patients. I want to do a good job, want the patient to be happy. Absolutely. I really, really try hard to make my patients have a positive, pleasant as much as it can be, experience, and we're both on the same page. But it requires an element of honesty, and I will lead on that. Are there any new surgical techniques introduced year by year? Question from Maro. So not so much year on year, Maro. There are amendments and little refinements and technique tips. So I did something with fixation for the scarf and wrote that up with my colleague at the time, Felix Lopez, who's a consultant now in Kent. So we wrote up a technique tip for fixation for a scarf. MIS is the biggest, oldest new kid on the block. So MIS Techniques has had a resurgence over the last few years, but it's been around for 40, 50 years, but done really badly. Now we've got better kit and some better techniques. It's kind of having a bit of a renaissance. As I say, tune in on the 8th of October and we'll have a bigger discussion about that. So there are little variances and little bits of amendment. Ultimately, it comes down to, so most of the good surgeons I know will have a range of techniques that they will employ, but they'll do them a lot so they get really experienced and crafted at doing. So I do about a dozen techniques, probably 4 or 5 commonly, but I'll do a dozen out of that 130. But obviously, if you're doing the same thing week in, week out, I mean, I can do 5 scarves, in a day if I'm doing 6-8 patients in a day, and so it's kind of a practice thing. Okay, 10 minutes to go. Should we go back to the PowerPoint, please, Brian?
Yeah.
Sorry, I'm having to slurp, guys, because I'm doing all the gabbing.
Ooh, good one.
Oh, that was an awful question, Brian. I can't believe you've asked me that. Okay, so had a patient 15 years ago. Mother had surgery, did great. She said, "Oh, you did wonderful work for me, Mr. Riley. Would you look at my daughter?" Daughter had hammer toes. Did the eldest daughter? She went great. Daughter said to her younger sister, "Oh, you've got a bunion. Go and see that nice Mr. Riley." So along came the younger sister, and we did the bunion, and it didn't go great. It was stiff. It had some recurrence, and she was just in a lot of pain. So I redid it, and it went even worse. And at that point, I noticed she was missing a finger. And she says, "Oh, yeah, I had a bit of surgery on my hand and it went terrible. I ended up with a really bad result and bad scarring, and they had to amputate my finger." And that was down to me not noticing that before. And I'd known this lady for about a year at this point now. So Oscar Wilde once said, a man that learns from his own mistakes is clever, but a man that learns from other people's is a genius. So basically, this woman now had 2 surgeries and had an awful result, and we had to amputate the hallux. It's the only time I've had to do it other than for diabetes. And so I'd had to take the hallux off. This woman's 40 years old, missing a hallux now. Then she got a nerve entrapment in the scar. And she was just the most delightful person. And I just felt lousy, and rightly, I should feel lousy. If it doesn't bother you, you're not doing the right job. Yeah. And even now, 15 years later, I still feel lousy. And she never lost faith in me, which just makes you feel even worse. And functionally, she kind of struggles. And in that time, her husband left her, and she kind of got remarried, and she moved away. And it was just, you just really want to help people, and it just and ultimately, it was just her particular tissues were just crap. But I was late picking up that was her. And I've had a similar experience with another couple of people, but that was the worst one ever. I mean, I've had patients in pain and infections, but that was the one that really sticks with me. And I just think, and yeah, I mean, what you should try and do when you have complications, I've seen pretty much every complication, apart from death, and a couple of my colleagues have had patients that have died on them, is when you see those problems, you've got to learn from it. And you've got to say, I've got to be better for the next patient and take that forward, so that while that experience and the result might be awful, and it's worse for the patients, it's not about my feelings. It's about, we're public servants. We're there to help people. Genuinely, I mean that. So when you have a case that's suboptimal, you need to be better for the next person and kind of pay that forward. We owe it to our patients. It's the least we could do. Helena just come in. Will this be available? Well, Mike Stevenson in the background, who's just this computer whiz, I'm sure he'll make it available. And he's promised me I can have a recording of it so it can go on my YouTube channel. There you go. Tomorrow's Podiatry. That's Mike's pseudonym.
think
Any more
it'll be on
questions?
Facebook.
Yeah, I'm sure it will be. So that's question 6. Question 7, Brian, was there any more, or did we kind of leave it there?
I think we'll have a look. Oh, questions
Question.
from anyone else?
On the point of review at 6 months, if a patient is experiencing pain or quality of life is suffering before the point of best, we're going to back to the original surgeon or get advice from a pod. Okay, so great question. So if you've got a patient that comes through with a problem, how can I put this without being too up my own bum? It depends, so if I've got a patient who's had a surgical complication and they're not happy, probably I'm going to be able to tell that patient why they've got a problem. Having been doing this job for 20 odd years and I've seen most of the complications, I've caused all of them. Generally when our patient comes back and they're not happy, which is quite common, you see lots of patients with little issues that will settle down with time. So generally I'll be able to say, right, this is why you've got a particular problem. So I had a patient yesterday, she's 6 months post Haglund's resection. Haglund's always take 6 to 12 months to settle down. So she came through at 6 months, she was still sore and still stiff and still swollen. I said, Sylvia, that's normal. It will get better by 12 months. So I will probably be the best person to advise on what that particular complication is. If you can get back to the original surgeon. Now, I'm a bit of soft touch. I really like to see my patients back because I like to kind of own that patient and own the complications of everything I can to get them better. And that's not common. I was chatting to one of my friends today who'd been under a different surgical specialty for a trauma and had an x-ray done, having broken her foot, and was discharged after 1 week, put in a boot and then discharged after 1 week. Okay. So that's kind of not the way I like to do things. So that friend and colleague of mine, will struggle to get back into the other surgical specialty to have a continued problems looked at, and that to me is not good quality care. So generally back to the surgeon ideally if you can, but in these days of episodic care and early discharges and limited number of post-op reviews, that's not always a possibility. So I guess for those of you out there who are aspirant surgeons in good pods, the more you know about surgery and surgical complications, the better you can advise that patient that maybe has had surgery elsewhere. Okay. Is osteoporosis, a question coming in from Yang, is osteoporosis a concern? Yeah, absolutely, Yang. So if you've got crappy osteoporotic bone, you will not want to do an osteotomy on that bone because it will crumble. And I actually had a guy in last week. So I did surgery on him 3 years ago for an arthritic bunion, and we knew he was osteoporotic, and we had to do a joint. We had to remove the complete joint. We planned to do an arthrodesis, but when I got in there, I had joint removal, a Keller's arthroplasty as a plan B. And when I got in there, the bone was more osteoporotic than I thought, and we ended up having to just remove the metatarsal head as well. So osteoporosis is an issue for breaking and resetting for sure. And generally, you've got an idea with the X-rays and the scans what you're going to get when you get in there. But sometimes you'll get some surprises which aren't always pleasant. So yeah, osteoporosis, that's a good question. Question from Anna: would it be good to have MSK bio teams in the same building? Absolutely. So that comes down to your ideal patient for bunion surgery has had good conservative care, but I'll see patients who are overpronating, because that's still a thing in Northampton. I've done whiz-bang podiatric surgery, hurrah, but that patient's still flat as a pancake. So I've done great bunion surgery. I want that patient to be managed orthotically afterwards long term. So yeah, in an ideal world, MSK would be absolutely wedded to podiatric surgery. That isn't always the case. It isn't the case for me locally.
I'm just going to have to jump in there, Ian. We've got one last question. We're running out of time a little bit, unfortunately. No, you can keep going.
Who knew I'd go over? How is that predictable?
We've got one final question from Magana, which is could you confirm the only universities to offer the full-time 1-year MSc are Huddersfield and Glasgow Caledonian?
So Huddersfield do now I might stand corrected. I know they do the 1 year full time.
Yeah.
And I think they still do the 3 years part time. I think.
Mine is 2.
Okay, so there you go.
Yeah.
I stand corrected. And then
often that happens.
and Glasgow Cali, so they share the program. So that still runs up in Scotland. And then every few years Glasgow runs it, and then the other few years QMU run it. So that's I think that's the kind of the 3-year version that's been running for the last 15 years or so. Eastbourne I did mine at Eastbourne as a postgrad, but I think they just stopped last year. I think they've just had the last cohort go through, sadly. So Huddersfield, but I'm a big fan of the Scottish programme, and I'm not saying that just because Evelyn's online. They do a great job. In fact, I'm going to be the external moderator for QMU come January. So I was teaching for Huddersfield last week, and I'll be up in Scotland. So I'm always keen to support the universities doing their thing. I've just got a soft spot for Scotland because of the fishing and because the people are so nice. Pastoral care, that's the word I was looking for. I said paternal care. Pastoral care. Sorry, Evelyn.
Gosh, that was like an hour ago. You've just remembered and jumped back. Well done.
Yeah. OCD is a bad thing.
Oh, that's great. We've just about run out of time. Thank you very much. Diolch yn fawr to everybody for tuning in and joining Ian and I this evening. Thank you all for your questions. They've all been really good. We filled our time really well. Ian's almost just about trying to run over. We hope you've found this evening really interesting and really informative.
Bryony, thank you for that. Thank you for hosting. Thank you for putting really good questions together and not shut me up too much. Apologies for kind of running over. And
no red herrings in there.
Didn't even do any gags.
Oh, no time for gags. Maybe next.
There's always time for gags.
Did
you hear about the guy that owns Dulux Paints? He's actually called Dulux. He was airlifted from the top of Helvellyn in Cumbria at the weekend. He was out walking with his family, and he got hypothermia exposure and had to be casevaced off by the mountain rescue, who said he needed another coat.
Oh dear.
Proper dad joke.
Oh, that was good. That was great. No, it was fine.
Michael's going to come in a second, do the outro, so I'm just going to just shut up and smile sweetly.
All right.